Hello, everyone, and welcome to Bankstown Lidcombe Hospital Emergency Department. These videos were created to support you in your quest to complete the ECG credentialing process. But please be aware that this is not an exhaustive lesson in ECGs. It only covers the basics. You should expect that your learning of ECGs will continue throughout your whole career. You also might feel that you already have a good grasp of ECG interpretation, and if that's the case, then please feel free to skip through these videos and go directly to the ECG quiz, which you can find here through this QR code, or if you have a copy of these slides, and you can also click on the link. The learning objectives of this session is that by the end of this session or these videos, you will be ready to complete the ECG accreditation process. And specifically, you will be ready to interpret an ECG in the setting of syncope, ischemia, arrhythmias, and also in an overdose. Okay, so this is the part one of these videos. I think there's four videos. This one's on ST elevation. Okay, so you see a 50-year-old, say a 50-year-old male with chest pain. And in the setting of chest pain, obviously your immediate concern should be, is this a STEMI versus could it be something else? So look for a STEMI first, and if you see it, then you're done. Just call cardiology. And here you'll see that you can see an inferior STEMI. So you can see the inferior leads, there's ST elevation here, ST elevation here, and also you look at AVF. Okay. So inferior STEMI. You might be asking, okay, well, remind me again what the STEMI criteria is. So obviously, it's someone with ongoing chest pain. So if they're asymptomatic, then you're a little bit more dubious about whether this is a STEMI. But ongoing chest pain plus ST elevation of 1 millimeter or more in two or more adjacent leads, except in V2. And in V2, there's a bit more of a complicated criteria. Sorry, V2 to V3. In V2 to V3, you require ST elevation of 2.5 millimeters or more in men who are under 40. If they're over 40, then only 2 millimeters. And if they're female, only 1.5 millimeters. Okay. There are such things called ACOMIs, which are acute coronary occlusion MIs, which don't necessarily fit the criteria for STEMI, but they're essentially STEMI equivalents, and we'll go through those in part two. But they include a left bundle branch block in patients who are hemodynamically unstable, or left bundle branch block in patients who are hemodynamically stable but with a positive modified Scarbosa criteria. The third one is a posterior infarct, and the fourth one is De Winter T-Ways. But we'll go through those in subsequent videos. So remind me again what the regions are. This is a good little table which will tell you what the regions are. Everyone seems to know inferior, which is 2, 3, and AVF. Um, the lateral, people seem to remember as, V5, V6, but sometimes people forget 1 in AVL. And anterior septal. So anterior is V1, V2, and septal is V3 and V4. Okay. Then you also may remember the concept of reciprocal change, and oh my goodness, how do I remember which region is reciprocal? It's even hard to say reciprocal to which region. And you can remember it by using the Pale's mnemonic. So P stands for posterior, A for anterior, I for inferior, and L for lateral, S for septal. And you'll find that the next letter in the mnemonic is the reciprocal area for the letter above. So anterior region is reciprocal for posterior. Inferior is the reciprocal area for anterior. Lateral is reciprocal for inferior. Septal is inferior for lateral, and then posterior ends up being reciprocal for septal, so it goes back to the top. And this is what it looks like. So if you remember the Powell's mnemonic, then you'll remember which area is reciprocal to what. And that becomes important and when we're trying to work out the differences between whether what you think is an ST elevation versus what may be something quite benign. Okay, that's just a reminder again of the areas. So if you had an inferior infarct using the Pale's mnemonic, you would expect um, reciprocal change in the anterior region. If it was a lateral infarct, then the next letter in the Pale's mnemonic is S, which is septal, and you'd expect a reciprocal change in the septal area, which is V3 and V4. Okay, let's move on to another ECG. So you can pause this video for a second if you would like, but this is an asymptomatic guy, but what can you see here? Obviously, you should be interpreting these in the clinical context. So immediately, you're probably less worried. It's a young guy, he's asymptomatic. And I've also told you to try to look immediately for a STEMI and look for STEMIs based on the typical regions that you now know about. But then you might be questioning here whether you think, oh, is there ST elevation here in the inferior kind of leads here? Or is this ST elevation here in the anterior septal kind of leads? And a common term that you might hear is, oh, that's not a STEMI, that's clearly benign early repolarization. And so great, what does benign early repolarization actually mean? And how can you tell the difference between benign early repolarization and a STEMI? Well, probably the first thing to note is that benign early repolarization may not be as benign as we think. In fact, a study in 2008 found that there's actually a higher incidence of idiopathic VF arrest in patients with benign early repolarization. So although we say it's benign, be aware that it may not actually be so benign. In fact, there's a syndrome called early repolarization syndrome, which refers to the presence of a benign early repolarization pattern on the ECG in those who have actually been resuscitated following an idiopathic VF arrest. Um, Regardless, this is still a rare complication of benign early repolarization, and the overwhelming majority of people with BER have no issues at all. So how do we tell the difference? So one of the ways that you can tell the difference is by looking at the J point. In BER or benign early repolarization, you typically, but not always, you typically have a notch at the J point. So see how it goes up and then it kind of comes down and you can see it's circled in red. You don't typically see that in an infarct. Okay, so a J point notch at the beginning of the ST segment. Don't be confused, however, between the notch J point and a fragmented QRS. So, fragmented QRSs, which can be seen, there's a bunch of different examples here, are actually a marker of myocardial scarring. So, and you get scarring obviously because there's been some kind of damage to the infarct in the past. And in this instance, Usually you have myocardial scarring from infarct. So you can see here, there's a little notch here. There's notches here at the after the QRS. Here, this one here, you might be thinking, oh, is that a J point notch in the but no, these are not J point notches. These are fragmented QRSs. There's a whole bunch of different types. And look at that one here. You might be trying to convince yourself that that's a J point notch, maybe even this one here. But no, these are signs of myocardial scarring, and it puts them in a higher risk category. Another way to tell the difference is by looking at the morphology of the ST segment and the Q wave. Um, So here you'll find that, oh look, there's a smiley face of the ST elevation. It concaves up. Okay. So as opposed to a ST elevation that is, I guess, convex, or you'd also worry about ST elevation that's also straight, that goes straight across. A smiley face is makes me much happier. Okay. The other difference you might see is that the you get a T wave that is asymmetrical. So asymmetrical T waves are less concerning. You'll notice that there's the descending limb of the T waves is a bit straighter and steeper than the ascending limb. So that is less concerning and is more suggestive of BER or benign early repolarization. A big one to look for would be that you don't have reciprocal ST depression. So again, remember we remembered the Pale's mnemonic. If we thought, oh, okay, there's an inferior, is there possibly an inferior infarct here? The next letter in the Pale's mnemonic after I is L. That's the lateral leads. Okay, I know that's V5 and V6 and AVL and 1. I don't see any ST depression in those regions, therefore, it's not likely to be a STEMI. Okay. The other thing to think about is temporal stability. So, benign early repolarization will not change. It's not going to evolve over the next 20 minutes or 30 minutes or an hour. However, obviously, a STEMI will change. Okay, that's why you get another ECG after 10, 15 minutes just to see how it's changed. So benign early repolarization has what we call temporal stability. There's two caveats to that, however. So benign early repolarization gradually disappears as the patient ages. So it's not temporally, I guess it has temporal stability, but over a long period of time, it will disappear. And then you'll also find that over very, very short periods of time, potentially you might actually see it. So, so what I mean by that is that the ST elevation and the J point notching is actually more prominent at slower heart rates. Okay. And it's less obvious when the patient is a bit more tachycardic. So you'll see benign early repolarization more at slower heart rates, and you'll see it less when they're more tachycardic. Okay? Okay, so is this benign early repolarization or a STEMI? This is a young patient with chest pain. And what you'll notice here is there's ST elevation in V2 to V4. So ST elevation here and here and maybe over here. And you think, oh, okay, well, it's a young person. It kind of looks like it might be a smiley face. It kind of looks smiley face. It's concave up. That surely is makes me happy. However, if you look here, that looks a little bit straighter in terms of ST elevation. And the biggest obvious clue to this not being benign early repolarization is that you have really obvious Q waves. Look at those massive Q waves. So this is obviously not benign early repolarization. This person ended up going to the cath lab and having a 95% occlusion of the LAD. Okay. So make sure that there's no Q waves is my point. Okay, now how do you distinguish now between benign early repolarization and pericarditis? Because that's another one to look for, another differential when you see ST elevation. Okay, one of the things that you should be looking for is the ST segment to T wave ratio. So if the ST segment, the height of the ST segment versus the height of the T wave is more than 0.25, then that suggests pericarditis. And if the height of the ST segment compared to the T wave is less than 0.25, then that suggests benign early repolarization. So let's look at that a bit closer. So here you will see, oh, there's some ST elevation. It's not particularly high there, so we'll say that's like 1 millimeter, whereas the the height of the T wave is about 6 millimeters. So if you do the math there, the ratio is 0.16. That is less than 0.25, and then so this becomes likely to be benign early repolarization. Okay. Versus the next slide, we have a situation where we have ST elevation of 2 millimeters and T wave, which is about 4 millimeters, and that's a ratio of ST to T of 0.5. And so that ratio is more than 0.25, and so this becomes more likely to be pericarditis. Okay, let's look at those next to each other again. So the ratio of the ST segment to the T wave, if there's a big difference, then that suggests benign early repolarization. If there's a small difference, then that's more suggestive of pericarditis. All right. The other thing to look for is the fishhook, which we've kind of talked about already, in terms of the smiley face. So if you look specifically at V4, again, you see the notch and the smiley face kind of picture. And people say, oh, that looks like a fishhook. So if you look at V4, you're looking for a fishhook sign in benign early repolarization. Okay, this is just a summary of what we've talked about. So in ST elevation, in benign early repolarization, it's limited mainly to the precordial leads, whereas pericarditis, it is generalized. In the PR depression, there's generally no PR depression in BER, but there is in pericarditis, but not always. And sometimes it changes over time as well. The T wave amplitude, we've said, is more prominent in BER and they're generally normal in pericarditis. And because of that, again, you see a ratio which is much less in BER. So there, which means that the ST segment height is much smaller compared to the big height in T wave amplitude in BER. Whereas in pericarditis, they're much more similar in size. The fishhook appearance we've just talked about too. Okay, so what about this one? Which maybe pause the video and you can decide whether this is BER or pericarditis. I'll give you a couple of minutes to kind of think and decide. But what you might be seeing is, oh, look, there's like a little, if you go to V4, okay, there's like a little notch there. There's a smiley face. It does look like a fish hook. So maybe this is BER. If you look at the ratio, oh, that's a very tall kind of T wave and a small kind of ST elevation there. And the ratio is probably less than 0.25. But then you look kind of further and you think, huh, there's PR depression kind of in a few different areas, such as here, maybe also in V3, probably in V2, maybe also in V4. There's also PR, maybe some PR elevation in AVR, which is reciprocal to all the other leads. And it seems to be fairly widespread, not just restricted to the precordial leads. And so the answer is actually, well, this might actually be pericarditis in someone with benign early repolarization. So maybe in fact it's both. So it's a tricky ECG. Okay. Just maybe to finish up, there's East a European Society of Cardiology guideline that came out last year, 2025, which gives you a diagnostic criteria for pericarditis, and which is essentially a clinical presentation, which is typical of pericarditis, the chest pain, and it might be sharp and it might be pleuritic, etc., plus one other of these. So a pericardial rub, ECG changes, which we've talked about, elevated CRP, or a new or worsening pericardial effusion. And obviously, the more criteria you have, the more likely it is to be pericarditis. Okay. Um, the other aspect of clinical presentation, I guess, would be, sitting, if you sit up or lean forward, that tends to improve the symptoms. If you are lying down, that makes it worse. If you are short of breath in the elderly, then that becomes more likely to be um, a clinically relevant symptom. Okay. Uh, so let's finish up with your learning points. So one is know your regions. Know the Pale's mnemonic for reciprocal change. Know the difference between BER and a STEMI rather than STEPMI. Sorry, that was a error. Which you should be looking for the J point, particularly in V4. Look for the smiley face. Look for the fact that you should not have reciprocal change in BER. There should be temporal stability in BER, and make sure that you don't have any Q waves. Okay. Also be aware if you're looking for that notch at the J point, be sure to tell the difference between a notch and fragmented QRSs. And then also our fifth point is we'll know the difference between BER and pericarditis. So look for the ST to T wave ratio, look for the fishhook, look for the generalized versus precordial leads, and look for some pre-out depression. Okay, so now we thought you were finished, but you actually have some homework. So what I want you to look up is look up what pattern would you see in a posterior infarct? And what would you see in a right ventricular infarct? And what type of ECGs would you need to get, special ECGs? And what would you need to look for to be for it to be suggestive of ventricular aneurysm as well? Okay. All right. So that finishes up part one. I'll see you in part two.